Hello, everyone. Welcome. My name is Paige, and we are here tonight for a great presentation. I am joined by Dr. David Tauben, and of course, we are here for a novel idea. Our presenter today is Dr. David Tauben, FACP. He is Emeritus Clinical Professor in the Departments of Medicine and Anesthesia and Pain Medicine, and recently retired Chief of the University of Washington Division of Pain Medicine, board certified in both internal medicine and pain medicine, and he has practiced as primary care physician for 30 years and pain medicine expert for over 25 years. David, thank you so much for joining us tonight.
It's my privilege and pleasure. So my backdrop here is the library in Bend, and I would like to thank the library system and the brilliant idea for this novel idea. First off, the name is really cool. And the notion that we can read together, even on Zoom in these challenging times, is certainly a great relief as well. So let me get started on the talk. I would like to also stress what's going to make this particularly interesting is hearing your questions, your comments, and please feel free as we're moving along to ask questions. I will capture them either real time, Paige will deliver them to me, and we will do our best at the end. I'm prepared to spend another 15 to 30 minutes answering additional questions and even some further discussion. So I also want to particularly thank Paige Farrow for the kind invitation, the great care she gave me throughout during the preparation, and the inspiration, because this is a unique opportunity because I usually live in an academic world where all I get to do is talk science. And in this opportunity, I'm going to be doing a lot of thinking more about the brilliance of our novelist. So though I have a backdrop of the Deschutes Library system, this is the backdrop that I'm now in. In reality, this was last night. I'm staying up on Lopez Island at a place that I've been renting for a number of years. And I, as a member of the faculty of the University of Washington, and frankly, a citizen in the state of Washington, certainly want to do a land acknowledgement for the Coast Salish people, which is where you're looking at right now, which touches the shared waters of all tribes, the Suquamish, Tulalip, and Muckleshoot nations, as well as the people past, present, and future of the Dakuapsh, the Duwamish tribe, Muckleshoot tribe, and other tribes on whose lands I live and we study and work. So another acknowledgement. This is a brilliant book. In fact, when I mentioned the name to my wife, who's a great reader, she said, "Oh, Lalami, she wrote this great book called The Moor's Account. You have to read it," which I had planned to do once I get my brain around this particular activity, because it has a lot of content relevant to our times, of course. And also as a person who spent life in medicine and dealing with the pain medicine and being in the middle of the opioid epidemic as a provider of care, her brilliance also extends into the characters, and particularly one who really is struggling with opioid abuse. And quotes from that character or from the author deals with the skirmishes in the endless war on drugs, reference page 162. And a further comment, "Now you are a bird, you float away free." And these really resonated with me on reading, even independent of the novelistic qualities, because of how carefully and appropriately she's touched on the opiate epidemic and how we got there. So today I'm intending to talk about opioids, from endorphins to OxyContin and then back again, just to ground this in a little bit of science so you can understand the nature of the epidemic and the challenges it's presented. I'll spend a bit of time about what is pain and why we suffer, how they're alike and how they differ. And what happens when you expose your brain to opioids and your central nervous system in general? Because the experience of pain is a body and mind experience, and they are both clearly affected. And then segue into the opioid epidemic, specifically what it is, and also how it happened. And then again, I'm going to stress again, I'd really love to hear your questions and answers and discussion, because this is how I learn as well from you all. So opiates go back a long, long time, 5000 BC. It was called the joy plant, and was recognized as having euphoric characteristics. The syringe in the 18th century really introduced opioids largely in the Second World War, and it was a result of the invention of the syringe and its promotion as a way of rapidly injecting a drug into the human body. And opioids were the test case. And in the United States, the Civil War was a tremendous opportunity to promote opioids as a pain reliever. And in fact, Civil War veterans returning both to North and South at the end of the war, based on the horrific injuries that they experienced, were very much affected by opioids. And it represented the first American opiate epidemic, as it's been described in the Journal of the Civil War era. If you're interested in that, it was a very significant problem at that point. On the other hand, it became popular as well as a soothing syrup. It was available over the counter, and as such, was even used in this case to treat children's colic. It's also caused helping teething, and it was called the mother's friend. Sadly to say, many mothers and fathers and sisters and brothers also became dependent on this product, but you'd be interested to know that Bayer, well known for its aspirin manufacture, was making it available over the counter as heroin hydrochloride for the relief of coughs. Again, widespread use in this country, and represented a very significant challenge which continues today. So what are opioids? That's a basic question, and here's a simple definition. I think it speaks to itself. Any drug that has specific activity on this receptor, the opioid receptor. It's called the mu receptor, mu for M, morphine. And this complicated little diagram here has lots of ways to tweak and stimulate, but any drug that has activity, either a promotion activity or a blocking activity, if it acts on the opiate receptor, the drug is called an opioid. Of that are the natural opiates from the poppy. The juice of the poppy is removed and purified, and it makes opium. Heroin is a first step derivative of opium to improve its overall absorption, but a lot of more familiar phrases that we now know: codeine, morphine, Vicodin, which, as you may recall, plays a significant role in the novel, or hydrocodone is its technical name, and Dilaudid. Many of you may have heard of those products over the years, and that's the chemical name is hydromorphone. So these are all derived directly from this poppy. In the United States, most of the poppy is not from the Middle East and India, where the rest of the world derives that, but from Australia and the Out Islands, where it's cultivated for manufacture of that chemical. In addition, pharma, which plays a big role in the epidemic, produces synthetic opioids. These are manufactured. So the term opioid subsumes opiates because these are synthetics. And these include the infamous OxyContin, which I'm sure you've all heard of if you've been paying any attention to the challenges we've had. Fentanyl, which is both manufactured by pharma and by, it's relatively easy. And with the internet, a lot of people can learn how to do it. And that's been a major contributor to the current problems with abuse and misuse. Methadone, and then Suboxone, which has a unique characteristic. It helps people recover from the opioid exposures. So these brands are all listed. It's a very widespread product. And it really mirrors what's called the endogenous, endo meaning from within. So our own natural opioid system, it was discovered in 1973, so relatively recently, at least in my career as a physician. And it was identified initially to be particularly associated with the reduction of physical pain. And that was a great discovery based on the ability to understand how pain relief was derived, because prior to 1973, how they worked was a complete mystery. So we do know that endorphins, and there's several types, but the common term is endorphins, regulate pain. And pain is a warning and protection system, a learned behavioral drive that allows us to survive. When we're injured, we protect that part of the body that's injured. If we feel that rising pain, it allows us to protect ourselves from increasing pain. We withdraw our hand from a fire, and we avoid problems we face when we previously slipped and fall on loose rocks. And as we grow up, we learn how to manage a very challenging external world to a fairly fragile body. And this learned response to pain is protective. It can backfire, however, and I'll speak a bit about that when we get into chronic pain. The endorphins also promote the pleasure and the reward system because they have an effect on social pain. So the endorphin response enhances satisfying physical behaviors. It promotes socializing behaviors, and endorphins rise in response to pleasurable experiences with others. And it also modulates and adjusts our endocrine functions that set us up for interactions with other people. And it likely perpetuates the human species by procreation as well, which are also very much part of the endorphin system. However, if we disrupt the endogenous opioid system, which is looking for painkillers, which is what we typically use opioids for, the question is, and I'm quoting my colleagues Mark Sullivan, Jane Ballantyne, are they painkillers or are they really just brain killers in many respects as well? So this is an interesting recent publication by my colleague Jane Ballantyne. It uses a word called hedonic homeostasis. So homeostasis is the body's maintaining its balance in terms of all sorts of regulation, procoagulation, anticoagulation, pro-inflammation, anti-inflammation, any system that elevates, there's a balancing system. This is a constant activity. And the processes that sustain that balance of positive life experiences like satisfaction, reward, pleasure, positive sensations. Hedonism speaks to that as a root word, but the word hedonic homeostasis is a description of addiction by the addictionologist, because we know and understand, particularly with opioids, that a high opioid tone, in other words, chronic exposure to opioids beyond what the body makes, i.e. the endogenous opiate system, actually produces a state of reward deficiency. So people who are using opioids for a long period of time have a blockage of the normal balance between satisfaction, reward, positive sensations. And we do know that patients who've been on opiates for a long period of time are more likely to develop pain that is unaccounted for. High dose opioid use, opiate abuse, depression, anxiety, and also a theme in Ms. Lalami's novel of post-traumatic stress disorder. And treatment of these conditions, post-traumatic stress disorder, we don't use opiates for, although they will block many of those. Depression and anxiety are also temporarily blocked as this homeostasis is interrupted. And of course, continuing use will develop tolerance, dependence, and all the subsequent challenges. Some very interesting work linking the social reward system and our pain system was done by Eisenberger and published decades ago, that found, and this is a nice cartoon that describes this. Don't worry about the abbreviations, but if you look at the pain network and the reward network, pain in red, reward in blue, the stimulation of reward network also leads to an activation of these adjacent brain structures. So they don't overlap, but they connect. I'll describe that a bit in a moment, how the connections of these areas of the brain matter quite a bit. And you can see what are some positive rewards: physical pleasure, having a good reputation, being treated fairly, cooperating, giving to charity, and interestingly, Schadenfreude, which is enjoying the suffering of others. These are all stimulations using functional MRI imaging of the brain that activate the reward network. But the same stimulation that are reflected in physical pains are also activated by social exclusion. The other Americans. You're not part of a social group. Social exclusion, we now know, is painful. This work was done the science was done in a scanning brain machine that had an avatar. They're playing catch, and you're getting the ball a lot, so your reward network is positive because you have a good reputation. And then suddenly no one's throwing the ball your way and you're socially excluded, and the pain network activates. So we're very sensitive. Largely as humans, isolation from the group is a threat to survival. I'm out on an island now. I hear all sorts of bird cries over the sea, and they're calling to each other, identifying themselves. I'm here, I'm there, I'm here. This is how you can find me. And we humans have our own social networking. And when this is interrupted, social isolation, bereavement, being treated unfairly, being compared negatively in a social group, activate the pain network. This was a real breakthrough in our understanding of how the pain system can be so activated in a host of life experiences. Many of them now have been identified. You may have heard of the ACEs, adverse childhood experiences, and the second ACEs, adverse community experiences. This is really interesting work that has now is being led in California, state of California, as an effort to address as much of these as possible. You will improve a whole host of conditions that are associated with medical diagnoses, when in fact it's unrelated to a bacterial agent, unrelated to a medical disease, but definitely related to physical, emotional neglect, divorce, mental illness, being incarcerated, homelessness, domestic violence, exposure to substance abuse in the family, sexual abuse, emotional abuse, maternal depression, and in the community, this whole listing of violence, housing, lack of opportunity, community disruption, discrimination, and poverty, they're clearly linked. The ACEs based on Eisenberger's work, with the pain network. And indeed, if we look at this work from Bob Anda, again, fairly old, but not that well understood, that these sorts of conditions, you can see them, they were listed in the previous slide, the ACEs, the more of them you score on, the more likely you're going to have these problems, which were first identified and have robust evidence. Suicidal attempts, depressed, smoking, alcoholism, multiple sexual partners, and therefore more sexually transmitted diseases. Social, emotional, and cognitive impairment, lots of learning disability in schools is purely attributed to the home environment, as we all know, and is becoming more of the public conversation these days. Many diseases, cancer, diabetes, hypertension. In fact, the parents also are suffering from this, as do the children as a result of these exposures. In the pain clinic, where I've been for the past 12 years at the University of Washington, we found an astonishingly high number of these ACEs. We did some work on this, and we identified the same correlation. The more of these, the more likely you're going to score these. And though chronic pain is not yet in the formal ACEs sequence, it is unquestionably part of that. Ann Case and Angus Deaton recently published a book, The Death of Despair. It's on your bibliography, potentially interesting reading. You need to warn people that you are really not in that bad a mood to choose a book with such a dreary topic. But they're two economists, and they looked at the reduction in life expectancy in the United States. This was pre-pandemic, when we've actually dipped again, but that was the first time, 3 consecutive years in the United States, that the life expectancy was reduced. And they wondered what was the cause. And as economists, they were looking at financial worry. And here's how much pain you have. Here's people who have high concerns, economic concerns up here. And you can see the amount of daily pain is just based on how much you worry about your ability to support yourself and your family. That has a high correlation with access to education, not surprisingly. And during the 3 years and the several years previously, drugs and death by alcohol poisoning rose 400% and suicides by 81%, leading to the increased death rate and this economic impact. So the phenomenon of pain and suffering is not just about physical suffering. It's about exposure to adverse childhood events, adverse community environments, financial concerns and desperation, and degree of education one's had, because they are clearly linked. And a very important case is made by Case and Deaton as to the impact of being able to support a family, and therefore it has increased the unmarriable state of particularly Black men, which was identified because of their inability to get economic position, and therefore were unable to get the things that make a lot of happiness and pleasure, like having a family, having children, having relationships with others. So it's a socially isolating experience that links tightly with economic factors as well. Work that our group has done, and others, references if you're interested, have identified that if we look at the patient populations, that the higher the dose of opiates given, this bottom line is representing the opioid dose, the odds of having depression, anxiety, childhood abuse, neglect, lifetime suicide attempts, alcohol use disorder, and using benzodiazepines like Valium or clonazepam, Xanax, and an opiate simultaneously went up dramatically. Again, demonstrating that life experiences unrelated to disease, unrelated to physical injuries, are associated with a drive, a necessity to relieve the symptoms of anxiety, depression, and sadly promote alcohol use disorder as well as benzo use disorder. And so this represents what are called adverse selection. And in fact, I'm often able to predict adverse events by looking at the dose and duration of opiates that patients have been using, because that is a driving factor. This is now well established in the medical literature. So what then is pain? What does that have to do with any of this? A lot, because pain is, again, unpleasant sensory experience. Obviously, we know what pain is. Also, people describe a negative emotional experience as painful. It's a word we use. And in fact, a word we use because that's how we feel. We feel our pain system activated by adverse emotions. It could be actual. I mean, your arm might indeed be over a flame, or the thought that damage is going to happen, and therefore we will avoid those. And people use the term of pain interchangeably in terms of something damaging. The pain system is activated by a thing called nociception. This is what we thought the target was, and this is what many people will attribute the source of pain from negative sensations just coming in. But it's far more complicated because there's a suffering component. Lots of descriptions of suffering. This is one of the ones I credit Daniel Carr, philosopher, ethicist, anesthesiologist, pain specialist, and have been one of my mentors along the way. He just, in a quip, said, I think suffering is a response to the experience of diminishment of one's capacities. So if you can't achieve what you hope to achieve, that's suffering. So someone with a spinal cord injury and becomes paraplegic as a young man, for instance, I've seen many of these patients with spinal cord injuries from either an auto accident or a diving accident or a bad event on a horse along the way. If there's the notion that you're never going to be who you saw yourself becoming, this plays a role in the novel as well, becoming a musician or becoming a physician, which was a weight on Nora, as you may recall. This issue of what people expect of you, what you expect of yourself, if you're unable to do that, suffering is possible. Pain is a requirement. Suffering is optional because we can frame our thinking and our life to have higher degrees of meaning. And I think, for instance, Nora did a great job of recognizing that music was giving her the life satisfaction, although there was certainly a lot of conflict and contributes substantially to the later storyline. And pain behavior is what we see. We don't know. We cannot see pain. Pain is invisible. We know that pain early on was thought to be evil spirits. This goes back thousands of years, where holes drilled in the brain of non-medicated, non-anesthetized patients to let the evil spirits leave. It was considered a religious punishment because of thinking badly or behaving badly. Here's a trephination event going on for this individual. Understanding of the four humors, them being out of balance, would contribute to the pain experience. Descartes, the famous philosopher and scientist, early scientist back in the 16th century, identified pain as actually being in the body. Here's that fire, and it triggers something in the body. This was a great discovery. It was thought to only be outside of the human body. The Persian manuscript from the 15th century identifies something striking. The question I ask my students when I'm describing what pain is, I say, what's wrong with this picture? I think you can see that this man has a severed leg. He doesn't appear to be behaving. The behavior of pain is not being demonstrated because he's continuing to fight. It's not clear what his thoughts might be. It might be, I'm finally going to get out of this war, or I'm going to become a hero. But the thoughts are elsewhere, and therefore the experience of pain, this is the damage signaling without pain. And we know that if we watch people run marathons, if we watch people play professional sports, the Olympics are coming up if they do occur this year, and you'll see people experiencing things that would ordinarily produce tremendous pain. But the process is not experienced as painful unless they lose. In the Second World War, Henry Beecher, a combat anesthesiologist, identified an Anzio Beach in 1942 as a horrific 22,000 casualties on both sides that led to horrific injuries. And his observation was less than half his patients, the injured soldiers they was treating, asked for anything for pain or even reported pain for up to 48 hours after. People call that adrenaline surge. Well, it's actually an endorphin surge, perhaps, but it's also the meaning and purpose of being in battle, and the ability to reduce suffering may occur as a result of that injury. So the nexus of having severe injuries without pain in 1942 is similar to what was described in the 15th century by combatants. Was it notable to him because they didn't even ask for morphine specifically. It took about 72 hours for these freshly wounded men to be able to feel the need for an opioid, and he describes that they complained more about a difficulty putting an IV in them, the venipuncture. If it was botched a bit, they complained more about the pain of that than about the rest of their body system. So pain hurts in a complicated way. If we pay attention to pain, we turn on salience. Salience means things are important. And if one is just paying attention to pain, it's increased. If one is paying attention to anything, the pain experience will increase. Alert or warning that there's something we need to be paying attention to. In a mind-wandering state, such as meditation, reflection, being comforted, being soothed, the system changes, and this reduces. So the pain system is suppressed when pain is present if your mind is not on it. So where our mind is at, where our head is at, will dictate the severity of pain. And this was done in a functional MRI machine, and people were being simply scanned. And if their brain was paying attention to bolts on the inside of the MRI machine, they were zapped. Their pain experience was higher. If they were just wandering, and they can map the brain in the default mode network, the DMN, this is this yellow thing. You could map this and find people in that mode. You give them the same zap, they didn't experience the pain. Some of them not at all. They said, oh, yes. They shifted to attention pain, and then the pain went up. And then we have a very complicated descending modulation. This is thought to be what is also going on in our soldiers and our own bodies by a central nervous system, up in the brain, but also in the spinal column, that's blocking, it's called the gate control, blocking the gateway of pain by pushing downward things that allow us to care for ourselves and get away from the predator, from our ancestors on the plains of Africa, in order to survive. So it's a survival mode to allow us to do what we need to do despite awful pain. And there's no location in the brain, and this is, I think, this connection system. This connectomes exist between the reward and the pain system, as I talked about earlier. This is a low back pain patient, and this is showing the different connections that are occurring in the brain with the experience of the low back and the different the fault mode or the salience network, et cetera. And the phrase is pre-existing brain states impact the experience of pain. So this is, again, very important notion that where our head is at will drive us to feel pain, pain of injury, actual pain of injury potential, or pain of social isolation. Any of those may be similarly affected. So how have we been measuring pain? This is a medieval image. It's actually a New Yorker cartoon from 2015. I might add that I got 20 copies of this in my inbox the day after it was published, because it is very relevant to the work we do. Excuse me. Here's the rack. He's being asked what's his pain. So his pain is going to go up. But we're still today, certainly 20 years ago, evaluating pain based on how much it hurts. And if we ask someone how much it hurts, it activates the salience network, and therefore the pain experience is higher. So we've been doing it all wrong. So here's the 0 to 10 pain scale. See the numbers? People children in particular, or patients who are aphasic or age-related or other forms of brain injuries may not be able to make reference to this, but the FACES scale is validated. We have different phrases. It's severe, moderate, or green. The key point here is the words that ultimately were added. This was the Department of Defense added this. They say it's as bad as it could be, but nothing else matters. So if nothing matters in your life, be it social, be it personal, be it your body is just unable to move as a result of a crushing fracture of both legs and your pelvis from a traumatic injury. If nothing else matters other than control, that's a 10. But it's this phrase here, nothing else matters. So finding meaning and purpose is one of the most effective treatments that we're able to offer for pain. And mindfulness, as we talked about earlier, is one way. And it's interesting and challenging that no one's ever died of an overdose of mindfulness. But there's certainly plenty of folks treating for things that are unrelated to body injuries, blocking our endorphin system, producing a dysregulation of our homeostasis, of our pleasure and reward system, can lead to such a significant challenge. And so pain got listed as a fifth vital sign. You may have heard this discussion. If you're not familiar with vital signs and the standard pulse, blood pressure, respiratory, and temperature, the notion was, let's ask about pain. The benefit of that is we're paying attention to the acute pain experience, which was the intent. Someone is having acute pain, and the solution is pretty straightforward. A quick fix: use opioids, because they really do work for acute pain management. The consequences, this measure began to be used for chronic pain. So if you're using an acute measure for a chronic condition, you're overlooking what we were just talking about: quality of life, function, mood, and sleep. And the problem really today, what contributed to physicians prescribing for pain scores alone, is that we have to pay attention to what else matters in the patient's life. Quality of life, what things we can do to give us satisfaction, earn a living, play with our friends, activate ourselves in both work and in recreational activities. Distress, mood, and sleep. Pain is not good to have, but just being depressed and not sleeping well is not a solution to the pain system's problem, but a much more complicated human experience that is a lot harder to manage. So I've taken to mentioning to patients, particularly those who are struggling in one way or other with their pain problem, and have used this expression: when your brain's on fire, I can't help your pain. So let's talk about how to reduce the brain fire, because people experiencing pain do not want to hear that it's a problem related to their head, because pain is not in my head, it's in my foot, my leg, my hip, my abdomen, my chest, any number of places the pain is. So it's a real challenge. And so we're striving to make it clear that the brain is an organ, and all those connectomes activating at the frequency and disorganized communication that's occurring deregulates our ability to cope with pain, cope with life, and we need to deal with coping as a primary treatment. So getting back directly into opioids, a very recent work just published in the Annals of Family Medicine, just recently, hot off the press, Mark Sullivan and Jane Ballantyne. I described very nicely, and this is one of the articles that I'm sharing with you all, that rather than helping the pain for which the opioid was originally prescribed and the patient was looking to get relief, the persistent opiate use is chasing in a circular manner, because it diminishes the rewards and normal sources of pleasure and increases social isolation as a result. So the problem with using opioids is you make the situation worse. And we have all sorts of terms for this. And this is not even related to misuse or abuse. It's called opioid-induced hyperalgesia. And it's a complicated brain experience that deregulates our whole complicated system of regulating and managing abnormal, unpleasant sensations. And the more you take, and in complex forms of pain, when they last for a long time, chronically means a long time, it interferes with not only physical, but social elements of that function. Again, work from Dr. Ballantyne, just to identify some of these other terms. We've been talking about the reward system, euphoria, everything's great. Anhedonia means you are unable to experience pleasure. So these gears grinding from pain relief, analgesia, to too much pain. And over time, tolerance develops. And with tolerance, dependence occurs, because if you stop the drug, one gets stress from that, from withdrawal symptoms, craving, and opioid seeking, which drives individuals into an opioid use disorder, or quote, addiction as a result. So the initial euphoria and pain relief, both charted here, is alleviated with medication. But over time, to just feel normal and to prevent dysphoria and hyperalgesia, the opposites, negative mood and increased pain, just not having the drug makes a problem. And taking the drug just provides a feeling of relief from these negative feelings. No longer benefits, they stop working. And the dose can be elevated briefly, you briefly overcome tolerance, and quickly, and depending on duration and dose, the rapidity of recurrence of tolerance accelerates further and further and leads to an awful vicious cycle that's been described. Now, we're looking at a term these days. This is the scientific criteria of opioid use disorder, otherwise known as addiction, versus non-addiction. And we're struggling between knowing where our patients are on this gray zone. The reason is that we haven't figured this out yet. We're looking at people who lose prescriptions. There's a reference to having to get prescriptions filled that have been lost. That's a good example of lost prescriptions. It jumped out at me when I was reading a later chapter in The Other Americans that describes needing to leave, pick up lost prescriptions, a characteristic of someone who may have opioid use disorder. No emergency room visits, early refills, no request for more, no urine findings that suggest they're misusing drugs, and no doctor shopping. This is a prescription monitoring program, which is now in place. So we are struggling now as physicians and treatment clinicians in being able to determine, are people addicted or not? It's even hard to tell and has become a further problem. Much of this began back in 1980. I remember reading this article in 1980, and I said, oh, that's good to know. Addiction is rare in patients treated with narcotics. Everyone was taught this is a terrible thing. The Civil War was a great example of that. And the problems that were associated with the non-prescription requirements, so people couldn't just pick it up at the drugstore on their own. Well, this article actually was a letter to the editor in a very prominent journal, and it was all touted as a New England journal. I wasn't told that it was a letter to the editor, and it was a very nice response fairly recently, a 5-sentence letter, someone counted it, published in the journal in 1980. When you looked at what they referenced, none of it was validated. Basically, they looked at 40,000 patients who were hospitalized, and they saw if they came in with addiction as a diagnosis, or they left the hospital with addiction as a diagnosis. And so few people had a diagnosis of addiction before they left the hospital after just a couple of days or a few weeks. They said none of these people are getting addicted. But as we saw earlier, it takes time to do that. And most folks who get started on an opioid get started in an acute medical circumstance, often in a hospital, often following surgery. So the question from the Physicians for Responsible Opioid Prescribing, it's the group that I'm a member of, was how can one paragraph be so harmful? So an early problem, my slide set is not working well here, but in 96 to 2001, Purdue, now an infamous company, published an Empire of Pain, just came out literally last week, that describes the whole history of this issue. We're providing physicians, pharmacists, nurses great benefits. They were sending patients, giving away swing is alive. So if your joints are bothering you because you got arthritis and you're getting older, you got to swing in the right direction with OxyContin. And between 1997 and 2002, there was a 10-fold increase in OxyContin prescriptions in this country. It went from quite a bit, 670,000 to over 6.2 million. And by 2004, OxyContin, it's a long-acting opiate, was the most prevalent alcohol that was abused. Purdue was identified as being guilty of misbranding the OxyContin, saying that it was not addictive based on data they had that showed that it was. More of that to come, but they just described it as not addicting because you didn't get a peak and a surge. It was a sustained release product. They got fined $634 million. No, they got $35 billion in profits. That's a nice cash return. They cost them $634 and they got $35 billion in response. But 2021, just this year, after thousands of lawsuits, they've been forced into bankruptcy. And the Sackler family, and this is the Empire of Pain, the secret history of the Sackler dynasty, got agreed to a $4.3 billion payback to state governments and other entities for the cost of the opioid addiction problem. And their net worth estimated at $14 billion. So we got there, as I mentioned earlier, from don't prescribe opiates long-term because it's a terrible thing because everyone's getting addicted, from that letter to the editor and heavy promotion that why should people be dying of cancer or only have acute traumatic injury if we could relieve suffering. And there was a big swing, and this is in Washington State, and I must say, mea culpa, I was involved in the group that felt that it was not appropriate for me to prescribe a few Vicodin pills to someone who had terrible knee problems and was not a candidate for knee replacement, and they were doing just fine. I was at risk of losing a license. We didn't realize at that time that that opened the floodgates. I mean, Oregon soon came around, and within 5 years, there wasn't a state in the nation that didn't have these intractable pain laws. When in fact, we were just treating pain intensity, not treating quality of life, not treating improvement in function, not treating mood and distress, because those are hard to do. It's real easy to write a prescription and get people out of their office. By 2008, 80% of the global opiate supply was consumed by Americans. And that calculated out to a nice catchy phrase, a bottle of oxys for every American. And you can see this map of other reasonably approximate population groups around the world. And here's the United States, leading the world per million of inhabitants in terms of the opiate epidemic, which has spread to Canada, somewhat to Germany, and these lines are all still out there. Australia has been managing theirs as well. Some areas, for a variety of reasons, listed here, did not go that route. What you don't see are the poorest countries because they couldn't even afford. In fact, in India, until fairly recently, I'm not sure what their status now is, you couldn't get an opioid prescribed in the hospital. Family members would need to go to the police station, collect the opioid, and deliver that opioid to a patient who is about to have surgery, for which they are indicated. So economic status and the wealth of countries, just like we're seeing with the COVID vaccine right now, the wealth of countries will determine the outcomes of disease and the ability to treat, in this case, a fairly negative outcome. And back in 2016, this is a graph from 2003 to 2014. You saw the opiate deaths rippling across America. If we take a look at Oregon here, it took a little while, but by 2007, it was on fire. 11, 12, 13, 14, it's a very significant national problem. This is a current map of opioid prescribing in response to lots of efforts that have been ongoing. So lower than the US rate. This is an applaud to what's going on in the state of Oregon and what's happening in Washington, California. What's notable to some is that many of these areas of over-prescription and still opiate overdose deaths, if you look at the case in Deaton work, are also those states have the lowest education level, the highest economic insecurity, and have been associated with lots of concerns about maintaining their identity, because if they lose their identity, they'll have nothing. So this is a complicated political issue as well. The map doesn't map purely to that, but it was somewhat striking in terms of the general political map of the United States as well. And we poor prescribing. We caught on early enough, but due to lack of knowledge and limited access to non-drug strategies, it's over $650 billion a year, and 16,000 still are dying from prescription drug overdoses, and 500,000, and that number's gone up even higher as a result of the illegal, the non-prescription opiates that are also available out there. So if we put it on the epidemic scale, some little math that put up, if you look at total epidemic, COVID-19 is going to take the award of the worst epidemic. HIV, 550,000, opiate overdose deaths, up there. And we're still counting because those lines are still going up. And if we look at the flu pandemic from 1918, these are kind of the overall epidemic. So we're putting the opiate epidemic as top 3 at this point. And current data, here's the prescription opiate line. This is the darker green image here. These are prescription opiates. You see something happened 2010. What happened was guidelines were first introduced in the United States. Our group in Seattle and the legislatures worked with guidelines reference to prescribing. We did a lot of work with Oregon colleagues, and they soon followed, and that's why those numbers are improving. But what also happened is that heroin took off. That's one of, that's the one that comes out from the poppy. And then the synthetic opioid, and they're not counting methadone because a lot of it is prescribed for opiate use disorder to keep people just level on a safer route. But this is referring largely to illegal fentanyl. And you can see that number suddenly took off. So at this point, it's not just the doctors prescribing. It's individuals using opioids that are illicitly obtained and it lead at this point to the epidemic that is transitioned from prescribed into illicit opioids. So we're hearing about waves of COVID, and the language is the same. The CDC uses the same words. In the 1990s, phase 1 was a marked rise in prescription overdose. 2010, as I showed, heroin jumped in, and prescription opioids flattened to some degree. And then 2013, the third wave is fentanyl, which can be illicitly made. This is for the general public. The CDC website on opioids and overdose deaths is rich with data. We're still collecting that data. Obviously, they've been distracted by COVID, as we all should be focusing on that as well as an acute crisis, that we can have a vaccine and other measures. Pain of life suffering, the going into opioids to soothe the misery of living and the distress of being socially disengaged and having no future. It's a lot harder of a problem to tackle. So since COVID, again, somewhat interesting, this is data very recently, this past month, in fact, from the CDC site. If you look in the 12-month period from September before the epidemic, which I placed here, it was going up a little bit, even before the COVID epidemic, but it's taken a significant rise. So it's further driven up. So the notion of social isolation, which we are obliged to do, or disengagement or disconnection from other people, has also contributed to an increased rate of opiate overdose deaths. If we look specifically at the state of Oregon, I did a little number crunching on this, and you can see, again, there was a little rise up, and it's went from 8% rise from September of last year, September 2019 through September of 2020, which is the most recent data. It takes a couple of months to get all the actual data. And that number is continuing to rise. So for Oregon, you're still struggling like the rest. So interesting quote. It's a little old now, from July 2020, from a Brown University epidemiologist, Tracy Green. Again, identifying social isolation has always been a huge component of drug overdose risk. So much of what we've been trying to do has been completely unraveled. So we're actually adding, superimposing one epidemic on top of another, and we're seeing the consequences of this dual epidemic. Lots of concerns have been raised about the patients who have been on opioids for a long period of time. They are tolerant. Their central nervous systems are wrecked and ruined in terms of their ability to hedonically homeostase, the ability to regulate pain, suffering, unhappiness, reward, and pleasure. The need for that drug is so overwhelming that patients are terrified by the discontinuation. And doctors have been criticized. Many are just abruptly discontinuing the opiate prescribing, partly because there's rules and other requirements that add burden to prescribing, partly the lack of alternatives for treatment. And quite a conversation is now underway for what to do with people who have been on opioids for a long period of time because of the intense amount of hyperalgesia, of recovery of a complex brain on opioids that's overall required. What's been said has been that the CDC guidelines, which came out in 2016, they've been weaponized, which is an interesting, another view, which is a further challenge. And I would imagine many of you listening have seen people just cut off from opioids. And there are higher incidents of suicide that's been associated with that. The numbers are less terrifying than early thought. However, it's still happening. Every death is a death. This article that was published 2018, this woman's husband committed suicide after the opiate pain prescription was severely restricted. Was that intentional suicide, accidental suicide? Was it driven by the chronic exposure to opioids? Yes, I think that's unequivocal. And the counter description has been provided that the predictors of suicide were a diagnosis of depression and lifetime suicide attempts. So the pain-related factors appeared not to be related. So it doesn't get any of us feeling better about this overall issue. But we have a second epidemic right now of managing patients who are dependent on opioids, the dependence and tolerance that has been developed, and the need to be compassionate, appropriate, and provide the alternative treatments that will be necessary for their bodies to unwind and come off that exposure. So what should patients do? What should we do when you have a pain problem? This is some interesting work done by David Butler and his colleague Lorimer Mosley. He and his team have been able to identify, actually through a public relations firm in Australia, a focus group series was set up, and it was determined that we're going to give up on the doctors and we're just going to teach the patients the questions to ask. If the doctors are asked this question, they're going to have to learn the answers. Interesting technique, but I like the way that's framed is my pain detection system broken? In other words, is this pain happening in the periphery, out in the nociception where the injury is occurring, or is the injury healed and we cannot find it there anymore? And then it's a sensitized nervous system that's playing a role. So if it's broken, we need to treat the broken pain system, not the pain as if it's from an acute injury. How can you fix it? And am I going to hurt myself doing this? I may have been told, and I recently heard from a patient that the high dose opioids and the high dose sedative drugs that was being prescribed, this is in Northwest Washington State, were because if she moved during the night while she slept, she might become a paraplegic based on a spine injury that really wasn't an injury. So the fear of hurting yourself to even move is another challenge that's associated with people who hurt when they move. We have to separate all that. and therefore it's complicated. So just some references for individuals to find if you, in your family or friend, neighbor is looking for an opioid treatment program general directory, and I just went on their site. I typed in Oregon, and this went on for pages and pages, but I wanted to be certain we had something close to you all. At least we got Portland here, Medford's in the south end, I know, Eugene west side, but look, Bend, Oregon. So right here, there is a program, and it's certified. There's a map to get there, and therefore help is available. Lots of effort is being pumped into this management if the people become dependent. Now, the stigma of being an addict or having opiate disorder is powerful. But if a patient's been receiving, a friend or family has been receiving opioids for a long period of time, they may need help getting off that. And it doesn't mean they have opiate use disorder, but they may require specific treatment to manage that. Southern Oregon has a very interesting site. I guess the North and South don't cooperate as well as we'd like. The Oregon Pain Guidance Group, a group that I've been working with for quite a while. I just went to their site 2 days ago, and there's a little thing on managing pain. Is it all in my head? What works? Lifestyle, how to talk about pain. This is a drop down on that. They list specifically sites relevant to their own geographic area. I just clicked on treatment and recovery. There's all sorts of other approaches, and also education directed direct to the consumer. What are the risks? Much of what I've been talking about are right and repeated in their overall site. They've done a really good job, and if you're looking for site, you're not going to find a Bend, Oregon, Deschutes County site on the Oregon site, but this is germane to any individual wherever they reside for the other patient self-help knowledge. So at this point, thank you for your attention. I really do appreciate your interest in the topic. My perspective, a bit different. When I read the book, I couldn't help but think of all the cool explanations for why this is happening, and then recognize that Laila Lalami was not in the science. She was observing this in the human sphere. And many interesting notions came up that are relevant, hence Paige's interest in sharing this conversation with you all. And I'd like to open it up for questions. So Paige, do we have any Q&A up yet?
Yeah, so during your talk, you mentioned this, specifically during World War II, how the soldiers' bodies weren't registering pain immediately. It took up to 48 hours for them to register pain, and that could be lots of different things, including endorphins or adrenaline. But is that also how the placebo effect works, that we are expecting something, thus we feel it?
That's a great question. So the placebo and nocebo. Let's take a minute to talk about the terms. We all know what the term placebo means, that we're expecting something to work well, and therefore when we're provided a placebo and told this is going to work well, it will work well. If you're given a placebo treatment, and we don't do placebo treatments in science anymore because they're not medically ethical, based on research guidelines, and that's quite appropriate. But we see a placebo effect from just the way the clinicians prescribe. So if I were to tell a patient, which I don't, here's a drug I don't really think is going to work, but it's on the list of drugs, and I give it to the patient, they're going to have no favorable response. If I have a lot of experience and success with a particular treatment, I will share that with the patient. I will describe, this is something that I've had a lot of experience with, many patients who had a good result with. I'm really happy to prescribe this for you because I expect, or the expectations, I expect this to provide you some relief, the drug will work better. Now, we know when we do research on animals, we can generate placebo responses to as well as humans, that up to 40% of the response to any pain treatment can be attributed purely to placebo response. If you could be given a little button to click that reduces the experience of pain, a little buzzing, unpleasant buzzing, and you're told that by pushing this button, it'll relieve the pain intensity, it does. If you're told that may or may not, we're not really sure, it doesn't. And we're going to say, no, this is just a placebo. So let us know what you think. You will not get a pain response. And that goes into that brain map that I was describing about salience. If you're expecting something, you're paying attention to relief, that's fine. Now, the opposite effect is also true. So that if you're expecting something to be negative for you, and I'm going to bring up Suboxone in this example because we prescribe Suboxone or buprenorphine. Many of you may have heard about that drug to treat opiate use disorder. We use it for pain because it's an opioid and it works really well for pain. The biggest problem we have in our clinic is patients say, I don't want to take something for addiction. I'm not an addict. I say, well, I'm not treating you for addiction disorder, I'm treating you for pain. Doesn't matter. They leave, they go to Google, Dr. Google, and Dr. Google has pages and pages of how terrible this drug is because people with opioid use disorder are not happy. They have opioid use disorder. They don't want to be on this. It's listed as a drug abuse drug, but in fact, it's really a primary analgesia. And therefore, when we give it to them, they have every possible side effect. A headache, they can't sleep, their stomach's upset. It didn't do anything for my pain, and they refuse to take it again. If I pitch it in a different way, I understand it a different way, and if the patients would just look less at Dr. Google and trust the provider to understand these treatments, the likelihood of a response will work. Is it directly connected to Henry Beecher's work? Yes, but I don't think as directly as it's set up to the expectation side. If a big injury, it's not clear what the patient's expecting. They're at least out of the battlefield. They at least survived. So it clearly has something to do with our endorphin system. It also has a whole host of other neurotransmitters, serotonin, norepinephrine, dopamine. We don't need to go into all those details. So this is the descending modulation system that I mapped out in that earlier slide that was relevant to this. So pain is really complicated. And if I do a lot of this hand waving, it's because I really don't know myself. It's a kind of a hand waving response. But the role of placebo and nocebo is a negative response. Another good example, and I see alternative measures I can offer my patients that's come up on the screen here. So another good example is we use antidepressant drugs often for pain relief. Now, many patients will say, I don't want to take an antidepressant drug because I'm not depressed. We do a depression score and they're off the chart, but they're not there for depression treatment. They don't want to be treated for depression. They feel stigmatized by having a diagnosis of depression. This means you have a poor character, you have a weak spirit. It's like trephinating that was done centuries ago, that it's got to do with your character, but rather than your circumstances and even your genetics. So I make it a point to say, this is a drug that was originally used for depression, but it turns out it works really, really well as a pain reliever. And it does. It works for chronic pain better than opioids. And they help people sleep. And I say, as a bonus, you're going to have a better mood. But let's treat that pain and we'll use that agent. So it's a way of how we overall communicate that. So what are alternative pain measures that I can offer my patients who are tapering from opioids during their hospital stay? Heat, ice, aromatherapy, spiritual care, opinions on what works best. Well, that's a really complicated question. First, let me just say that heat and ice are very effective. Rubbing helps. So even massage, acupuncture has been described to be very, very effective if your hospital system is acupuncture. In fact, at Seattle Children's Hospital, there was an introduction of acupuncture. The parents insisted on it. The hospital resisted it. There were so many parents saying they don't want their children to be on opioids. Can we use acupuncture? So, all right, we'll have to do it. They were going to support it. It turns out it was such a gangbuster operation, they had to hire a second acupuncturist, and the hospital was not losing money on the acupuncture. And in neonates, who don't really have their expectations, these are infants who were born prematurely and are in neonatal intensive care units, NICUs. They need to be sedated because they got lines and wires and ventilators. It's this awful experience for these children. So to comfort them and to soothe them, a lot of drugs were necessary. So they decided to try some little acupuncture needles. So they put these tiny little acupuncture needles suitable for infants. They just put them on the acupuncture points, and just the wiggling around of the child would move the needle around, which is part of acupuncture stimulation. They found a dramatic reduction in need for sedatives and opioids. So this is not expectations. This is the complex system. So the most historically longest and traditionally recognized treatment for a child, or even a human in pain, is to hug. That's the social isolation switch. So as a physician, you're not going to be hugging your patients in the hospital, but having family members in, providing comfort, rubbing and soothing, ice on the opposite leg. You can't put ice or heat on a leg that's maybe in a cast after a hospital stay. You put it on the opposite leg, it works on for the opposite side even. So we have a social worker working on meaning and purpose in the hospital, identifying other social support systems, beginning to address depression and anxiety in a non-threatening way. If there is an opioid use problem coming into the hospital, at this point, we are introducing buprenorphine in the hospital. So bringing someone down off opioids in a hospital setting, it takes a while. The taper strategies for tapering patients off opioids was originally described as you can drop 10% every week. I will take personal responsibility for that. I spouted that out in a meeting in 2005 before our opiate guidelines in Washington State came out. What should be the rate? I said, well, you can do it every day, 10% without precipitating withdrawal. Let's say every week. And it just got published. It's before I was at the university, so I wasn't really into having to prove everything academically. And then I looked that up because there's in all these guidelines, and the reference was back to the Washington State opiate guidelines. So we've taken that away completely. The CDC has taken that away completely. So we would suggest a 10% taper every month. And if the patient's struggling, it's every 2 to 3 months, the taper may be necessary. And you can't do that in a hospital. So tapering opioids during a hospital stay is a real challenge. I think the goal is, if you're in the hospital and needing pain relief, don't rely only on opioids. Try to find other measures. Music therapy, a great treatment. Bringing in video games, if it's a guy who likes to play video games, for virtual reality experience. So virtual reality experiences will provide some relief. Talking with someone, just being cared for, allowed enough sleep, make a big difference. So during a hospital stay, if we're going to drugs, using an antidepressant category drug can help. You use probably Flexeril a lot, that's cyclobenzaprine. It's actually a secret antidepressant drug. It came out as a muscle relaxant, but it's molecularly so similar, it's one hydrogen atom different from amitriptyline or Elevil, that can be used because it'll help sleep. And after about 2 weeks, there'll be benefit associated with the use of that drug when they leave the hospital. We use gabapentin also because it helps sleep and is not too much of a problem, although people will get into the abuse pattern there. So I'd say tapering opiates during a hospital stay, it's a tricky business. It's identifying a post-hospital follow-up plan that will allow patients to be brought down at a rate that's compatible without generating this awful suffering and suicidal thinking and drug seeking and relapse behaviors. That's the goal. And that's where you need to find a program that's available following discharge. Next question is, how can we advocate for rural areas to gain access to treatment programs? There you go. That's a complicated, it's a policy making decision. And I'm going to harken back to the Southern Oregon group because they've done a lot of collaboration with the health systems and the local governments that are increasing numbers of providers, and the health systems are increasing the reimbursement rates for that kind of service. So if it's opioid use disorder that's taking place right now, I think the treatment program answer is going to be having providers get buprenorphine trained. It's called wavered. I'm certain that the doctors on the call understand that. Currently, it's a lot of hours of training. I don't think it's necessary. We can prescribe we can prescribe methadone for pain, OxyContin for pain, and Dilaudid for pain, and you can't prescribe buprenorphine for opioid use disorder. It's safer. Buprenorphine leads to far fewer opiate overdoses that are associated, produces less craving, and it seems to have mood elevating response. So actually treating part of this complicated challenge that patients have. And that earlier slide of the mu receptor, there's also a kappa receptor, and there's some opioid receptors, and so buprenorphine also interacts on those. So any primary care provider, nurse practitioner, osteopathic physician, medical trained physician can prescribe buprenorphine, and it can prescribe, and the individual can prescribe buprenorphine for opioid use disorder. Why don't they want to do it? Because it's a stigmatized condition. And they also don't want to take care of every opiate addict in the community because many of these people don't have work and they don't have insurance. But the overwhelming number of people who have opioid use disorder are functioning people. If we look at the characters in the book, we had a highly successful dentist who had opioid use disorder. And so you can't tell by looking at someone the way they dress, certainly the color of their skin, and there's a huge amount of prejudice against Black and brown people, referring to they're more likely to get addicted. In fact, that's not true. It was white folks in the case of Deaton data that were associated with a higher incidence of suicide, opiate overdose deaths, and the like. But yet it's still stigmatized. So the other, again, the title of the book we're reading, are thought to be more of a problem, more dangerous, and providers want to walk away from that. So the simple answer is you have access if you've got practitioners in the community. They just need to be buprenorphine wavered. And the way that has to happen is through medical society and physician detailing, people coming in and explaining the advantage, doing the numbers, looking at the satisfaction that folks have. And I know there's been a lot of work done in the Eugene area by a collaborator that's been working with us, and substantial work done in the Medford area and other locations where there's large community activities. So if there's any way to get folks together and start to talk about this, that would be helpful. So I would also suggest you can contact me subsequently by email, the questionnaire. Maintaining privacy, I'm not going to read your name out, but you're welcome to contact and query as to a program we have. It's called TelePain, where about half the cases we hear about are people, providers, struggling with patients who need access. And we educate people on getting wavered with Suboxone. And many of the conversations that we have on a weekly basis, I shared much of them with you today, so we can get into a more in-depth discussion at that point.
Fantastic. All right, David. Is there any link that you know of between the legalization of marijuana and a decrease in other drug use?
Yes, very controversial. Again, the data that we've been looking at have been what we call ecological data. They haven't been really studied, but we just look at big pictures. So states that had and not recreational use, but medical cannabis permitted, were compared in terms of opiate overdose death rates with states that did not have medical cannabis. There was a 15-20% difference in opiate overdose deaths. The patients were soothed enough by the presence of cannabis to get themselves off opioid or dose reduce opioids. So the data is kind of squishy at this point. The cannabis data for in terms of pain relief is solid enough to be appropriate in many cases when it's proved otherwise, but cannabis is not a benign drug. Cannabis is associated with cannabis use disorder. Just like alcohol, people can drink alcohol, or people can have alcohol use disorder, i.e. alcoholic. The same issues arise. Cannabis in combination with alcohol, dramatic increase in automobile accidents. That's probably the most serious concern. And the younger age onset of cannabis exposure, the greater the likelihood of a whole range of adverse effects, including the induction of schizophrenia and other more difficult learning issues that are associated with it. So cannabis is not a risk-free agent. But my own practice, when I'd say, I'm really concerned about the cannabis use, I'm not willing to continue the opioid prescribing. When you're using the cannabis, the patients will say, I'll take the cannabis. I won't stop that. And I'll say, okay, then I'm going to reduce your opioid by 50% just for the safety issue that's associated with that. And patients will go for that alone. The data is not great. So the original question, what's the data? The data is based, as far as I know, on large aggregate data, which would not be considered as trustworthy. Patients will report they feel better on cannabis, helps them sleep. The CBD has less psychogenic effects, and therefore the sleep issues, the calming effect without the psychedelic effect may be a bit safer. So this is an area of great controversy in medicine. We don't want to create another epidemic by recommending cannabis widespread. If a patient is going through an opioid taper, I don't have any problem if they're tapering and they're using cannabis. There's no specific adverse interaction that has been identified between combining opioids and cannabis. It's really alcohol that's the biggest issue in an overall combination.
Okay. We are coming up on time here. One last question, and it's kind of a big one. What can we do as individuals and systemically to help curb the opioid epidemic in America?
All right. Well, the part of the epidemic is related to medical prescriptions for management of pain. So understanding pain and having providers who understand pain and limit the amount and duration of opioids. It was just give more, give more, give more. It doesn't matter how long it takes because that little letter to the editor said it was not a problem. And it was an easy way out. But understanding the pain is very complicated. It's not just the sensation coming in, but it's function, quality of life, mood, and sleep. And those can be managed quite successfully without tolerance and with good effects without opioids. So the pain side flattened. It's not going down any longer, and there is a little bump since COVID. Again, I think that's the social isolation component and the fear and the threat that COVID presents. As far as the illicit drug issues are concerned, that's a greater challenge because at this point, fentanyl is so widely available. I think education of young people, destigmatizing the fact that if you have opiate use disorder, that's okay. I will care for you and give you treatment. I mentioned buprenorphine or Suboxone. That is a remarkably safe agent. It is an opioid, but it doesn't produce the respiratory suppression, which is why people die of the drug. And it caps off in terms of the respiratory depression, unlike opioids, which just keep going up and up. So increase access to Suboxone or buprenorphine treatment programs for those treated. Counseling. What's driving the addiction phenomenon is what this book is about. Adverse childhood events, adverse community experiences, and then access to something that sort of finally makes you feel better. I'm not in that place anymore. The fact that I'm socially isolated doesn't bother me. The fact that I'm not working doesn't bother me. So it puts you in a bit of a stupor state, and that provides relief because, don't forget, the endorphin system works for social and life distress as well as medical injuries that are associated with the production of pain. So it's a great question, a whole separate conversation. So I think we're out of time. I want to just get one quick credit. Paige, can I? I'm going to hold people for just a second, because your observation of the use of, I'm going to actually pull up my one slide on this. I was just saving this here. Share 1 second, because it'll include additional information. You mentioned that the one tiny chapter of Salma, the dentist, the older sister, says, now you are a bird, you float away free. And the whole chapter, she never uses the word I, us, me. So what Paige had told me, said, it's really interesting that the whole section is written in the second person. And I had to think, what's second person mean? But you're all literary people. You're attending this as a book club event. So writing this whole thing in the second person is really unusual. So it's about you, not me or them. So I think, and the reference is available that I provided, that the use of you actually has been identified with social and family isolation of individuals. And when people are exposed to the you term, the parts of their brain that activate are activated as if they're socially isolated. So I thought this was a great observation by Paige, and got me thinking about the fact that this is actually published information as well. So credit Paige, and thank you to the Novel Idea program and all of you folks who've been listening, because it's been a real fun opportunity for me to reframe this into a language of this audience.
Well, David, thank you so much for joining us tonight and providing so much great information. This was really fantastic. We are so grateful to you. And thank you to everyone out there for joining us tonight. Novel Idea is made possible by our sponsors and by you. You are coming to our programs, and that's what's keeping us going for 18 years. Thank you so much. Check out deschuteslibrary.org to catch all of our other fun free programs surrounding this year's community read, The Other Americans, and make sure to join us on May 2nd to hear author Laila Lalami live in conversation with Jason Graham. Thank you again, everyone. Have a great night. We hope to see you soon.